Good morning.
Good morning.
I think it's still morning. I don't have to introduce these people. They're very, very famous. Tony Fauci is an historic figure in medicine. And I'm not saying that to make you feel old, but you are an historic figure, and Vanessa Kerry will one day be an historic figure. And I'm very glad to have you both here. We're going to talk about pandemics, and there's so many diseases to talk about that let's just jump right in. Tony, the last time we spoke, I think we do this about every 6 months, and every 6 months I ask you the same couple of questions. So I'll ask you to start with Zika and just give us an update on where we are. It has receded as a concern. What's your biggest worry going forward?
Well, going forward right now, the thing that I'm concerned about is Puerto Rico, because as we get into the July, August, real humid, heavy mosquito months in Puerto Rico, we're concerned we're going to have a recrudescence or a rebound of what we had. Puerto Rico got hit quite hard last time around. Right now, in Brazil and Colombia, where the bulk of the infections were in South America, we're going into their winter now because that's the southern hemisphere. So it is unlikely that we will have a big blast there, although it's unpredictable. My concern is the following year around, after the rest of a year, like right now, this past summer in Brazil, which was our winter, was not nearly as bad as it was the previous time around. So what we're doing is we're just pushing right ahead with the development of a vaccine, which we're already testing right now in Texas and in Puerto Rico.
What have you learned from the Ebola process that you're applying in Zika?
Well, the rapidity with which we were able to get a vaccine off the ground, it's very interesting, not very well appreciated fact, but from the time that we got the sequence of the virus of Zika to the time we put it into humans in a phase 1 early trial for safety was about 3.5 months, which is the quickest in the history of vaccinology to go that quickly from one to another. So even with that, we still are in a situation where we have to prove that the vaccine works, and the only way you prove it works is if you get cases. So on the one hand, you don't want to see any more cases, but on the other hand, if you don't, we'll never definitively prove if the vaccine works. But I think there will be enough cases, enough low-level endemicity. May take us a couple of years to prove that it works, but I'm pretty sure we're going to get there.
Vanessa, what keeps you up at night?
Other than my children, what is keeping me
There's
up?
no cure.
There's no cure for that. You know, what keeps me up at night right now, I think, is the fact that I worry that we don't have an attention span around really big problems that we have to stick with over time to stop, right? So I think a lot of people panicked about Zika, for example, when the Zika epidemic was really a big deal, in the sense that it was every day in the media, we were confronted by it. But, you know, to Dr. Fauci's point, Zika is still a very real problem. It's just we are not necessarily putting our same degree of cautionary practice or implementing programming or getting, in, what's really important is the funding stays there over time. And I know this because the work that I do is a time-intensive approach to health, health problems.
So talk for 30 seconds about your work, just in case people don't know what your organization does.
So I run an organization called Seed Global Health, and what we're trying to do is to ensure that the world has enough healthcare professionals to be able to not only care for the patients that need to be cared for, but most importantly, to be able to train their successors, so that we constantly have a pipeline of well-trained doctors, nurses, midwives in the countries where there are these that are lacking resources and have huge health problems. So if you look at it, to relate it to pandemics, if you look at a country like Ebola happened at the scope and scale that it happened in Liberia because there were not enough doctors, nurses, midwives to be able to, recognize the epidemic, sound the alarm, and mount the response. And so actually the reason we now work in Liberia is because the president of Liberia herself asked us to come and help her country scale up the needed health professionals so that she had a healthcare system that could care for the population, stop pandemics, and be able to sort of address all these responses. And so, but it takes time to train people, so for example. And so we worry, so the things that worry me is that to tackle really big problems and to make them fully go away and to be thoughtful, we need to not only be ahead of the game, but we need to be willing to see them all the way through to the end. And I worry about attention spans in funding and political will to see that through.
Speaking of political will, Tony, I don't want to put you on the spot, except actually I do.
You do.
The Trump administration, they ready for a pandemic?
Well, I hope so. We had the opportunity, as I was mentioning to you backstage, of right at the end of the Obama administration, Dennis McDonough, who was the chief of staff for Obama, brought a few of us together to essentially address the question that Jeff was asking me, is to brief the cabinet of the soon-to-be administration. This was the gap between the election and the inauguration, about 4 issues. One, a regular terrorist attack with bombs and bullets, another Hurricane Sandy, a cyber attack, and an outbreak. And what we did is that we outlined what we had been doing over the last many years in preparation for an outbreak, and hopefully the resources and funding for that will continue over the next few years. I hope so.
I mean, I think that I know that he's been briefed on the fact that the biggest, risk for this country going forward from, a safety and security standpoint is going to be non-state actors, and secondly, cyber attacks, and thirdly, pandemic. So, I mean, I'm hoping that with that knowledge and that focus that they're willing to really, listen to that. And I think very importantly, there are a lot of good people working at NIH and CDC and, the State Department still that are, don't roll over with an administration that are very aware of this.
That was extraordinarily diplomatic.
It's my
Could you
job.
talk about, runs in the family, could you talk a little bit about the funding challenges? There is a proposal on the table from the Trump administration to cut the budget of NIH, to cut the budget of CDC. Vanessa, will you talk about, specifically in the case of CDC and pandemic control, what that could mean for American population, not just global populations outside this country?
Yes, I mean, I think 2 parts to the question. I mean, CDC is really critical to our surveillance, our global surveillance and our domestic surveillance for diseases and disease patterns. And to understand how it's spreading, what the, rate and rapidity is, who's at risk, understanding sort of, being able to do the subsequent planning for it. And they train people too, really critically importantly. They do a lot of training in countries and places where they're, at least internationally, there's a huge degree of risk, so that these countries are empowered to do their own surveillance. And a budget cut to the CDC would be devastating, just because we arguably need to do more already in that than we have traditionally, especially when it comes to scaling up our partner countries where a lot of these epidemics can originate. And so, but, I'm optimistic because I do think that, one, I think optimism is deeply needed right now, realism, but optimism too. And I think also because if you look at Congress's response to the budget, what the president has put forth in terms of budget, the Congress has responded not always by adhering to this cut. So PEPFAR, for example, did not see a cut in funding this year necessarily, and that was, I think, a great...
Just do 10 seconds on PEPFAR in case anyone here...
PEPFAR is the President's Emergency Plan for AIDS Relief. It was started about 10 years ago, a little longer, and it's really our gigantic multi-billion-dollar global effort to help stop HIV, and it's really helped change our definition of what's possible in public health. We put millions of people on treatment with this medication. We have, so it's been a tremendous program, and that funding, at least this year, was protected, and I think that that's a real statement that there is some understanding of what can happen. So I'm hopeful that Congress also will protect some of these budgets.
So, Tony, the H1N1, the last time, 2009?
Right.
I think 2009, that you in government experienced anything like the approach of a pandemic. Tell me how government responded. Tell me how CDC and NIH and every other division responded to that. Tell me what cuts would mean.
Yeah. Well, cuts
in that context.
Well, in that context, Jeff, cuts would be devastating because what we had to do is that we had to move extremely quickly, because in the spring of 2009, we started to see the beginning of these cases in April, which is when the flu season is essentially downgrading and you don't get much flu, which predicted that in the fall of 2009 that we were going to get an outbreak. So we had to move very quickly, and a lot of supplemental money was put in, superimposed upon a budget that was stable. If you're thinking in terms of cutting a budget and not having the flexibility of the kind of supplemental money that we had with Ebola and that we had with Zika, we would be completely left in a way that we would not be able to respond adequately. So you have to be flexible. It's more than just flexibility and supplement. You have to have the core things that you do, that the CDC does, and that
You mean
we
you
do
literally
every
need to
day.
have a pile of money you could spend today?
Right, as well as working. For example, you don't just react. It can't just be a reactive mode. You have to have the kind of scientific preparation. The CDC has to have the kind of networks that they do to be able to detect. That's ongoing. That's sort of below the radar screen. You don't hear about it or read about it because you don't have an outbreak. But once you have an outbreak, those things immediately spring into action. And they don't just happen spontaneously. You have to support them chronically over a period of years, the way we have been doing up to now. And that's why things like budget cuts make me very concerned about our capability of being able to respond adequately.
Can you talk about, in this context, in the context of disease surveillance, can you talk about the kind of work that her organization does? Because it seems like, in addition to going into communities in sub-Saharan Africa, mainly at this moment, and working on basic healthcare, these people that you're sending are also sentinels in a kind of way. I mean, maybe Tony can talk about that, put that in a global context, and you could add on to that.
Yeah, well, first of all, what we have and hopefully have is a global health security network. The word security is because it's actually part of security. So what you need around the world is the ability of people, and you have to build infrastructure for that, to be able to recognize and communicate when you see outbreaks. Those are the kind of things that are the network of security. I'll let Vanessa talk, obviously, about what she does, but she's in a non-government organization which is on the ground implementing the kinds of things that we, in our own way, through research and public health, kind of synergize with what she does.
So so with this idea that we're training local healthcare providers, that we've partnered with the governments in the countries where we work very intentionally. When the Ebola outbreak happened in Liberia, we worked with governments in Malawi and in Uganda and Tanzania around Ebola preparedness in the countries where we were working, helping to do education and training, and also to think through sort of how you could empower folks to respond appropriately should these epidemics, have an outbreak. And I think that while they certainly are sentinels, I think one of the powerful things they do, though, is that the volunteers, the folks that we send to work for a year in Africa, come back here to this country, and the vast majority of them are working with underserved populations or in academics or in major hospital centers here, and they're bringing that skill set also here, so that when we think about our own home preparedness and our ability to identify certain diseases or certain issues here as well, I mean, they're bringing some of that knowledge here home also, which I think is going to be increasingly important at a time where, with climate change and things, mosquitoes are moving northwards. We are also at risk of some of these epidemics, and the ability to identify them and be thoughtful about how to respond.
Part of the political discourse these days is obviously about borders and border control. Obviously, the current president, when he was a private citizen, made the argument during Ebola that flights should be canceled and borders should be closed. I know what the received wisdom and the broad wisdom in the infectious disease community is about that issue, but I'm wondering if you could, is there any credit you can give to this idea that we should be more fastidious or more immediately reactive to outbreaks in other parts of the world by trying to seal us a little bit tighter than we are?
Well, obviously, there are some diseases in which, for example, back in the day when we had the SARS outbreak, that it was appropriate at certain times to have quarantine of people who were coming in with a respiratory illness. But that's an unusual situation. For example, and I'll give you a concrete example, Jeff, that the audience would appreciate, that one of the things that came about during the Ebola outbreak was perhaps we should not let people in and out of those countries. That was something that we had to argue very, very forcefully against, because if you don't control the outbreak in a place like West Africa, which was Liberia, Sierra Leone, and Guinea, then you have the possibility that it's going to spread even further to very populous countries like Nigeria. The way you do that is by cutting off a country and not allowing the supplies and the free flow of individuals to come back and forth. So by isolating them, you're having the paradoxical effect of making it worse. The other issue was something, for example, and it had been suggested and we argued against it, with Zika. Zika is something that was in the Americas, in the Southern Hemisphere. in Brazil, hundreds of thousands of cases. The question is, should we prevent people from coming from the southern part to the northern part of the Americas? That would have not been effective at all, and that only would have caused a great degree of chaos because there are about 300 million people a year that go back and forth. So to think that you're going to cut that off would have economic impact that would totally supersede any benefit that you would have from that. So you've got to be really careful when you talk about restrictions in travel, when you're trying to isolate a disease.
I think the best way to protect ourselves is to shut it down at the root cause. Right. And then but that requires an open policy where in the sense that you go there, you provide resources, you provide expertise, you provide people, and there naturally has to be this back and forth in order to shut it down. Also, I mean, the last time I checked, malaria doesn't get to the border of Rwanda and say, oh, I'm done, right? I mean, things move, air travel, things happen, and people will find a way there. So you shut down the one flight out of Monrovia because of Ebola, but everybody goes through Europe. You can shut down every flight out of Europe. I mean, I think that what needs to happen is a smarter policy.
There's some people who would say yes.
Yeah, well, they'd still argue that now today, probably. But I think that there's a much more effective way. I mean, it cost us $1.1 million to treat 2 people with Ebola in the United States. That money applied, in situ in West Africa would have been far more effective. And I get that people get scared and want to protect themselves, but at the end of the day, I'd like to also think there's a moral obligation to take care of our fellow global citizens also, and to not sort of turn our backs, but to be also thoughtful about what the implications are if we don't step in and sort of help provide the support and expertise that we can.
We're going to go to questions, so if you raise your hand, there's a microphone. There's one over here, Lindsay. And then there are people above us.
Sure.
Look at that.
Oh, okay. Hi, John Kinsdale. First of all, thank you both for your service to this country and the world, particularly for decades, Dr. Fauci. I want to ask you a question that has to do with policy and politics, but in a way that will put you on the spot. It seems to me that the public health community has done little, at best a poor job, of promoting the incredible government-funded public development of the kinds of things that you do. Obviously in an atmosphere now, a political context in this country in which there is a tremendous amount of dismissal and contempt for what government can do. And I'm just wondering if you have, and also what you do is pretty exciting. I mean, it's as exciting as ER there are movies about pandemics. Is there anything the public health community, public health schools, the private sector can do to kind of try to dramatize and make the incredible service that NIH and organizations like yours, Ms. Kerry, do more publicly recognized as a really important government function that actually comes out of the federal government?
He's asking who would play you in a movie.
That's a good question for the Atlantic.
Yeah. Well, the answer is yes. We obviously need to, and we hope, and we try to do that, is to continue to talk about and be very vocal and articulate in the need for public health infrastructure. One of the problems, and I face this because I have the opportunity to testify before the Congress a lot, because every time there's an outbreak like this, there's 20 hearings that you have to testify at. And the point that is very, very clear is that it's very difficult to get people excited about something that hasn't happened yet, that might happen. And it's really easy to get people to overreact to things that have happened. So what we're trying to do is to work that golden mean, that delicate balance, to try and explain what preparedness means. Preparedness should be something that is essentially there and chronic for you, and not something that's up and down.
Do you have to scare people more?
I don't like to...
No, I mean, you're using that language on purpose.
Yeah.
I mean...
One of the problems with scaring people is that if you do it when the situation is not really one for which they should be afraid, it's not the right thing to do, but even as important, you lose credibility. So when I get up before the Congress during the period of time when we had Ebola, and it was get back to what Vanessa said, is that we needed to stop it in West Africa. So I made the point to President Obama and to the Congress that we needed a lot of money to go there and be able to build the infrastructure to leave it and stop it there. That wasn't a scare tactic. That was a reality test that we did it. If I came and said, well, if we don't do this, everybody in the United States is going to get Ebola, that's A, incorrect, and B, my credibility would have been destroyed because that's not the way Ebola spreads. You want to stop it where it is so you don't get that few cases that'll cost us millions of dollars to take care of, including the one I took care of myself. I took care of an Ebola patient who was a healthcare worker at the NIH, and the amount of resources it took care for us to take care of him in an intensive care setting for about the 11 or 12 days that he was sick was an enormous cost. You don't want to have that in this country.
Right.
I mean, I agree. You don't want to be an SOS funny. I'm laughing because my 5-year-old and I just talked about the boy who cried wolf. So I have great respect for that story. But you don't want to scare people, but you sometimes have to rely on sensationalism. It can be the truth, but you have to be opportunistic, right? And I will just give an example. So when I try to tell people about the work we do, I will introduce it with the fact that 1 woman dies every hour from a complication of pregnancy or childbirth in Tanzania. We sent an OBGYN or an obstetric doctor to go work in northern Tanzania. And on her first day there's a knock at the door, and she was called to the operating room immediately. She goes to the operating room, and there's a pregnant woman on the table who's dying. She can't save the mother. She tries to deliver her first ever postmortem C-section, and she has 2 dead twins. She's devastated by this. But she goes back the next day when she's called again to the operating theater emergently, and she sees the mother again is dying, this time from a ruptured uterus. She can't save the baby, but she saves the mother's life. This mother had 5 children, which means his mother will now go home to her 5 children who are less likely to grow up economically and socially disadvantaged. But far more importantly, she had all of her local counterparts in the room with her, learning how to do the same surgery so that they can go and do it. And so she transformed the rates of death for women in northern Tanzania. True story. It's stories that are powerful, and we need to tell those stories, and we rely on our partners like the Atlantic to help us do that, and we need to be very thoughtful about it. And the hard part is a lot of us who are physicians like me or doctors, that's not what we're raised or trained to do, so it can be difficult, but we need to do it. And we rely on all of you. In this day and age of Twitter and Snapchat and Facebook and viral everything, YouTube, you can help us make these stories viral and the importance of this viral. So I put a little bit of this burden, not just on us as a community, but on all of you to say this is important and a priority and something that we need to do.
Hi, I'm Monique Mansura, currently a researcher at MIT, formerly privileged to work with Dr. Fauci and part of the enterprise that is the US government's effort to prepare for pandemics. I have a question about links to the previous question, the value of vaccines. Some have argued, again, that we're at risk of losing tens of millions of lives, percentages of global GDP, and yet the value of the vaccine and the government investment in preparedness, we're seeing low value and significantly up to 10-fold reduction in government investments in preparing for a pandemic influenza. So the question is this something inherently governmental? And it links to the other question too. Is there more that individuals, communities, corporations should do to help be prepared, including and up to and including the development of vaccines? Should that be something that we are all more engaged and invested in?
Right. The answer is a resounding yes. Obviously, we should be. And one of the things that we have to do, and it's a role of government, and I feel really strongly that it is that industry is critical to the development of countermeasures like vaccines. But industry, in part or maybe even mostly, it has to be a profit-developing organization because they have board of trustees, et cetera. So they need to have a link between some sort of a profit margin and not take a major risk. So what we in government do, when I say government, I'm talking about the research component, my institution, the CDC and others, we try and take the process of vaccine development and de-risk it for government, for industry. By de-risking it means that if industry did it alone, take a malaria vaccine, Jeff, and we need a malaria vaccine, we need a TB vaccine, and we certainly need an HIV vaccine. If industry were to do it alone, it would cost them billions of dollars without any guarantee that they were going to get the end game of what they wanted with a product. because you're not sure you're going to get it. What government can do is to put the investment in concept development, preclinical studies, early clinical studies, to take away that risk so that when you get it to the point when it looks like there's a pretty good chance we're going to get a vaccine, that's when industry comes in. So I think we should emphasize the responsibility of the government. And in my mind, the government is all of us in this room, because the government represents the people of the United States. And I think it's our responsibility, morally and otherwise, to be able to do those kinds of things that you're talking about, to make vaccines so that you don't have a baby dying every few minutes of a particular disease like malaria or tuberculosis that kills 1.8 million people a year. We do have the responsibility to do that.
Vanessa, I want to give you the last word.
And vaccines are also, I think, there's a global security component to it as well, in the sense that, you need to, if you have children that live longer and people do well, you're less likely to have more children be born. A country like Uganda that still doesn't have decent vaccination rates, for example, it's going to triple its population from 33 million to 110 million this year. Over the next decade, sorry. So there's an importance to this, to making those kinds of investments. The government should be invested in it as a global public good that protects its population in a way that, allows for investment, a healthy, productive workforce, and frankly, prevention is more cost effective than the treatment side of things.
I want to thank our two panelists today for a great presentation, and on behalf of The Atlantic, and a thank you to Margaret Lowe and her whole team for doing this. The Atlantic, we believe, stands for fact-driven discourse, analytic rigor. This is a 3D manifestation of what we stand for, and I'm very grateful to all of you for coming out today. Thank you very, very much.